So welcome everyone. Thank you for being here on Zoom. I'm delighted to introduce our speaker today, Liz Ackert. Liz is an associate professor at the University of California at Santa Barbara, and prior to UCSB, she was a postdoctoral researcher at the Population Research Center at the University of Texas at Austin. Liz's research focuses on racial ethnic inequality, immigration, education, health disparities, and urban geography. She's particularly interested in understanding how the attributes of immigrant receiving contexts influence the educational and health outcomes of Latino children. Liz has received funding from NICHD and NSF and has published in numerous journals, including Demography, Journal of Marriage and Family, Social Science Research, and Population Research and Policy Review, just to name a few. So today she'll be talking to us about place-based differences in Latino health across U.S. destinations. And we will go ahead and hold substantive questions until after Liz's talk. If you have any quick clarifying questions, though, Liz said that you can interrupt, and then I will do my best to monitor the chat. And after Liz's talk, we'll go ahead and open up for questions. Thanks, Liz.
Thank you so much for that lovely introduction. And I'm sorry I couldn't be there in person, and I'm glad that you were all able to make it here on Zoom to hear me talk about resources for health and well-being across Latinx destinations. So I'm an associate professor in geography, and I'm also an APC fellow for this year. So let's see, I guess I gotta do this to advance. Okay, so here's a little bit of an outline for my talk. I'm going to talk about the background and motivation, specifically changing Latino community contexts. Also, just to let you know, I'm going to use the terms Latino, Latinx pretty interchangeably during this presentation. I'm going to talk about why destinations matter for Latino health. Then I'll present my research questions. I'll show you the destinations typology that I use in most of my work. And then I'll go over 4 studies and findings, which can be put in these broad domains. One is health context across destinations, and the other is child health outcomes across destinations. And then I'll give some conclusions and future directions for work in this area. So I'm interested in changing Latino community contexts, and I'm interested in this one dimension of Latino destinations, but we can also think about how destinations are intertwined with a lot of other trends in changing Latino community contexts that have been happening in the last 3 to 4 decades, like the suburbanization of the Latino population, segregation changes, as well as gentrification. I'm not going to hit on all of those things today. I'm going to talk a little bit about segregation in one of my studies, but the focus of this talk is on this one dimension of changing Latino community contexts. And so this is a map of new Latino destinations at the state level. So the established destinations are in places that you might think: Texas, California, the Southwest, as well as Illinois because of Chicago, and New York, Boston, places in New Jersey, as well as Florida. Those locations are mainly because of the Caribbean Latino origin populations. It's funny, on this map, Michigan is not a new destination. And in fact, I will show you some data indicating that Michigan is in fact a new Latino destination. Okay, so these destinations are places that had a negligible or very small presence of Latinos prior to 1990 and then experienced rapid growth thereafter. The reasons why they emerged, I'm not going to get into that too much, but basically there were changes in industrial restructuring. So locations of functions like meat packing, food processing changed geographically. Those functions themselves changed. So for example, food processing of many fruits and vegetables became a year-round enterprise. And then immigration laws and border control actually had the unintended effect of ending circular migration and promoting settlement of Latino immigrants, and then who would later go on to have, families and descendants in these areas. I want to make the point, which I'm going to reiterate later, that most new destinations are not new anymore. We still call them new destinations, but they're actually pretty well established at this point. So by 2000, about a quarter of Latinos were living outside of these what we would call established gateways in these new destinations and other counties. By 2010, about 1/3 of Latinos were living outside of the established gateways. It's important to note that this dispersion to new destinations, or what we would call the geographic diversification, has mainly been driven by the Mexican origin population, less so among the other major Latino national origin groups. So this is to show an example with Michigan. You can see that in 1980, there were fewer than 200,000 Latinos living in Michigan. And then by 2022, it's nearly over 500,000. So the population over doubled in size from the 1980s through around 2020. And so this is my example with Kent County, Michigan. Okay, so I was going to do my Michigan map. And so Kent County, I think, is here based on what everybody told me. It's where Grand Rapids is located. And so you can see Kent County has been an important Latino new destination. You can see steady growth of the Latino population in Kent County, mainly driven by that Grand Rapids area. So with the growth of the Latino population in Kent County, you see the rise of things like a welcome plan for Latinos and immigrants. You see the rise of community-based organizations like the Latino Community Coalition, the Hispanic Center, and the Somos Comunidad Fund. And this is very typical of many new destinations. And so for my work, I try to think about why destinations matter for Latino health and well-being. And so we could think about two big frameworks for considering why destinations might matter. One is a place as a social determinant of health lens, and the other is literature on destinations and immigrant incorporation. So this is a social determinants of health framework. I'm sure many of you are familiar with this framework. And as you know, many components of the framework have place-based elements, right? They vary across location. Things like health care access and quality that I'm going to talk about today, neighborhood and built environment, social and community context. These all vary according to where people live. And I've been building out what I call a social spatial determinants of health framework. And so this is an example of how distal factors, or what might be called fundamental factors, can eventually shape proximate determinants of health, and then health outcomes and health disparities. So this is a framework that some students and I have developed based on a Schultz et al. Framework on segregation and health, and then Bronfenbrenner and Morris's ecological context framework. So we could think about how destinations shape community or are intertwined with community resources for health, like safety net care, and then how they both shape health access, stressors, health-related behaviors, and ultimately health and well-being, as well as disparities in those outcomes. And then we can think about why destinations matter, specifically for immigrant incorporation, which can shape health outcomes. So the first reason has to do with intergroup relations. These are things like whether the community is hostile or welcoming or somewhere in between for these newcomer groups. This can also have to do with pre-existing intergroup relations between racial and ethnic and immigrant groups in a place, and then how Latinos kind of come into the fold of those relations. We can also think about size and potential for intergroup contact, things like segregation and isolation. So how likely is it that a Latino child is going to come into contact with a child from a different racial, ethnic, or immigrant group in their typical day, for example? And then lastly, we could think about institutional arrangements. So these are things like the availability of bilingual services at schools or clinics. So these, we often think about these as targeted group resources. And so we could think about how these three bins of factors also shape health and health disparities across places. The prior literature, there has not been a ton of prior literature on health outcomes across destinations. There's some work showing lower health utilization among Latino adults in new destinations. So work showing that US-born Mexican-American adults in new destinations are less likely to have a usual source of care, more unmet care need, as well as less adult health insurance coverage in some new destinations. There's also been some work on the Hispanic mortality paradox and trying to see if there's variation in that paradox across destinations. And these results have actually shown a mortality advantage in new destinations. So Hispanic mortality rates being lower in high growth versus established areas, or Mexican immigrants in new and minor destinations surviving longer than those in established areas. And so the research questions I'm going to tackle today are new destinations more positive or negative context for health and well-being than established destinations? I'm going to show you some work that I did. I published it in Health Affairs in 2021 on health context across destinations, and then some work that I have under review where I look specifically at this one resource of fairly qualified health centers across destinations, and also incorporating segregation as a potential explanatory or moderator variable. And then I'm going to turn to looking at health outcomes among children, addressing the question of whether Latino children in new destinations exhibit better or worse health and health relevant outcomes than those in established destinations. So I have some work that I published with Stephanie Potocnik that came out last fall on health access and utilization among children across destinations, and then some emerging work that I'm doing on health outcomes in early childhood across destinations. So before I proceed talking about the studies, I want to show you my typology that I use. I use pretty much the same typology across all of my studies, and we can talk in the Q&A if you want about the sensitivity of results to the typology. I actually have another paper that I'm working on that topic. So I'm going to show destinations as measured at the county level in all of this work. My data set contains just over 3,100 counties, and the county boundaries are harmonized to the 2010 census boundaries. I get the data from the decennial censuses for 1990 to 2010 from Social Explorer. This is a group-specific typology, so I'm looking at change in the presence and growth of the Latino population specifically. So I'm not necessarily looking at immigrants. I'm looking specifically at the Latino population, which includes both immigrants and US born. So I look at the base Latino in 1990, and then the growth from 1990 to 2010. So this is sort of a schematic that helps to show how I place them into categories. So basically, if in 1990, the county had 9% Latino or higher, which was the mean percent Latino across the country for that year, then it's considered an established destination. In some of my work, I further distinguished the fast-growing hubs, those that had high growth, and sometimes I just lump those all together. Then I take the non-established destinations and I divide those into the new destinations that had equal to or higher than median growth for all non-established destinations from 1990 to 2010. And then those that don't meet that criteria go into this other group. I do make a couple of exceptions here. So this is basically if there was an other destination, but they were 16% Latino by 2010. So that was the mean for that year. I put them in the new destination group. Conversely, if there's a new destination, but they have a very, very small Latino group presence, so less than 5%, I put them in the other destination category. So this is the typology, what it looks like across counties. So you see the established destinations are in many of the places that you would suspect. There's also some, agricultural areas, for example, in the Pacific Northwest here that have always had Latino workers. And then the new destinations are dispersed kind of throughout the Pacific Northwest, the Midwest, and the South. So when we think about the spread of Latinos across these destinations, you can see here under established that the vast majority of Latinos by 2010 were still living in established destinations, right? Even though the percent of all counties that are established destinations it's a small group. Around 18% of Latinos were living in these new destinations, and then 13.5% were living in other destinations. And you can see the other destinations made up the largest group of counties, just because that's where everyone else is living. So this shows kind of what the percentage of Latinos in these groups looks like over time. So as you can see, the established destinations have always, and this is by design, have always had, much higher percentages of Latinos living there. Then this is the national average. This is the new destination group here in sort of the orange color. And then we have the other destinations below. So you can clearly see that the established destinations remain important areas of settlement, and then they have just much higher Latino populations than the other two groups. And the next graph shows percentage growth for each decade, 1990 to 2000, 2000 to 2010, 2010 to 2019. And so this is really where I want to make the point that the new destinations experienced the bulk of their growth in this period, 1990 to 2000. They continue to experience some growth in the 2000s to 2010s. And then that growth for pretty much all destinations really leveled off in that period from 2010 to 2019 because of the Great Recession. Net migration was actually negative during that period. So you can see that the bulk of the growth was happening in this earlier period. And that's also why I say that new destinations are not new anymore. Really, they came on the radar in the 1990s and they've become established now, even though they have these lower percentages of Latinos living there. So I'm going to talk about my first set of results, which have to do with health context across destinations. Are there any questions about the typology before I get started? Okay. So I'm going to focus on a few characteristics of what we might call health context or the health ecology of a county. So the first thing I'm going to look at is what are called health shortages, health professional shortage areas, and medically underserved areas. Then I'm also going to talk about one specific type of health services called federally qualified health centers, or FQHCs. I have a bunch of other data in my data set on destinations. I have a bunch of data on other health personnel and health services. I have the RWJ county health rankings as well as 287G agreements. I don't have time today to get through those results, but I'm happy to talk about them if you'd like. So what we would call a HPSA is a health professional shortage area, and these occur in 3 domains: primary care, dental care, and mental health. Then we have medically underserved areas. Now, these are designated by the Health Resources and Services Administration, or HRSA. There's different scoring criteria that used to designate a county as a HPSA or a MUA. I included that as extra slides if anybody wants to talk about the specific criteria that they use. But it's important to note that these criteria are used to try to marshal resources towards communities and populations in need of affordable medical care. I'm going to focus on geographic HPSAs and MUAs. So this is when there's a shortage of providers for the entire population within a defined geographic area, in this case, the county. I have, so I'm going to look at these primary care HPSAs, dental care, mental health. I also calculate whether a county has all 3 of those designations, and then whether it's a medically underserved area. And I'm looking at their designation status as of May 2020. Then I'm also going to look at federally qualified health centers, or FQHCs. So these are clinics that provide comprehensive primary care services to medically underserved areas and populations. They get specific federal funding for doing so, like Section 330 grants, Medicare, Medicaid reimbursements. And in return, in order to get these grants, they have to meet strict compliance and reporting requirements. So FQHCs are a really important part of safety net care in general and for Latinos specifically. So Latinos are a growing patient group among all patients at FQHCs. In 2022, 38% of patients were Latino. This is over 11 million people. And as you can see from this graphic, the share of Latino patients that FQHCs are seeing has increased over time. And so these FQHCs are supposed to be placed in medically underserved areas or serving medically underserved populations based on this IMU score, this formula that you see here. One important thing to note is that an FQHC must be placed in a medically underserved area, but not all medically underserved areas have FQHCs. So these are the results. These are just descriptive results. I'm not controlling for anything here. So we see here that when it comes to health professional shortages, established destinations across every category, the established destinations are much more likely to have these shortage designations than new destinations. That's true whether we're talking about primary care, mental health, dental care, or all three. So we're talking about the difference between the bars in turquoise and the bars in orange here. This is true also if we look at medically underserved areas. So here we were weighting according to the population that's Latino in the county. We see the same pattern where the established destinations are much more likely to have these MUA designations than the new destinations. And then I also wanted to point out that the other destinations tend to be kind of somewhere in the middle. Now turning to the federally qualified health centers and community health centers, which are actually a subset of FQHCs, we see a different pattern. We see that the established destinations actually have, they're more likely to have these federally qualified health centers than new destinations. That's true if we're looking at federally qualified health centers overall and community health centers specifically. And so we see that new destinations have some positive health and well-being aspects of what we call the health context, because they're less likely to be designated as this health professional shortage areas or medically underserved areas. But we also see that there might be these barriers for immigrant origin groups specifically because they have fewer federally qualified health centers and community health clinics per capita. And so we wanted to dig a little bit more into that FQHC disparity across destinations to try to see what was explaining this disparity. And also to try to see if segregation was playing a role. So was segregation explaining the differences in FQHC supply across destinations, or was it playing a moderating role? So we hypothesized that maybe established destinations that are the most segregated would have the greatest supply of FQHCs, just because of those criteria for how FQHCs are allocated. And so for this sort of sub-analysis of that broader work, we're using the FQHC data from HRSA through 2019, using the Latinx destination typology that you saw. We calculate segregation metrics from the ACS 2015 to 2019, using tract and county estimates. So we calculate the index of dissimilarity, which is a measure of spread or clustering of Latinos and whites in the county. The Latino White Isolation Index, which is a measure in the average Latino neighborhood, how likely is a Latino person to come across another Latino person. We use a variety of control variables here that have to do with the medical underservice criteria. So the descriptive results are very similar for FQHC supply, as I showed you before, where the new destinations have way fewer FQHCs per capita than the established destinations. Here, actually, the other destinations have the highest supply of FQHCs per capita. When we look at segregation, and maybe this is not surprising, it's actually been found in the prior literature, that highly segregated counties, based on dissimilarity, have the greatest supply of FQHCs. We see a similar pattern when we look at counties that have high levels of Latino isolation as well. And so we bring these together in a mixed effects logistic regression model where we predict, does the county have any FQHC? So is this county basically, you know, if it's a 0, it's basically what we would consider an FQHC desert. It has no FQHCs in it versus having one or more FQHCs. In the first model, we're just looking at destinations and segregation. In the second model, we add an interaction between destinations and segregation to see if there's this moderating role that segregation is playing. You can see we control for a bunch of variables here that are related to population composition, also that they're likely related to medical underservice. And so the results here actually show that in the first model, destinations in this net adjusted model, they are not significantly related to whether a county has at least one FQHC or none. But the Latino white dissimilarity index is positively related. So again, the more segregated counties have a higher likelihood of having any FQHC. And then surprisingly, there was not a significant interaction between destinations and dissimilarity. So it really was just sort of this segregation association, positive segregation association with FQHCs that we're seeing. When we look at isolation, instead of the dissimilarity index, we see a very similar pattern where Latino isolation is positively related to having any FQHC, destinations are not, and we don't see any moderation of the associations between destinations and having any FQHC by isolation. So basically, what we find observed differences in FQHC supply across destinations that disappear in these adjusted models. So we conclude that destinations are not an important factor predicting FQHC supply, but that Latino white segregation is an important and positive predictor. And then again, we didn't find any significant interaction between destinations and segregation in predicting having any FQHC. So now I'm going to jump ahead and talk about some of the findings on childhood health and early childhood health across destinations. And so the first study is looking at health access and utilization. Here in this study and in this next study I'm going to talk about, we use the Public and Restricted Use National Health Interview Survey, or NHIS. We get the public use data from IPHMS, and then we merge that with restricted use data via NCHS in an RDC. And I was just saying that I'm very thankful for the federal workers that I work with who helped to facilitate this process. The restricted data needed to access the county geocodes. We have to use the restricted data because we can't get the geocodes without them. And in fact, we don't know which counties the children live in because the analyst does all the data merging for us. I'm going to use this destinations typology that I've shown you. As I've mentioned, I have a bunch of other data that I've also merged in. I'm happy to talk about those results in the Q&A. I just want to show you this disclaimer from NCHS that these findings and conclusions are those of me and my co-author, and they don't represent the views of NCHS or CDC. In our sample, we have children ages 4 to 17, and we divide them into 4 focal groups. So we have Latino children of immigrants, Latino children of US-born parents, and then for reference, we have non-Latino white and Black children. We're looking at 3 health access and utilization outcomes. So does the child not have any health insurance versus public or private? Have they experienced delayed medical care due to cost in the last year? And then do they not have a usual place of care? And this is what I refer to as the subsample. So one thing that the NHIS does is it has some measures for every single person in the household, but other measures only for one focal child who is sampled. And so when I refer to the subsample, I'm talking about those measures that are only available for that subset of children. So this is the results when we pool all of the racial and ethnic and immigrant groups together. We actually don't find many differences between new and established destinations. And in fact, we find that they are less likely to have no insurance, meaning they are more likely to be insured than children in established destinations. But when we look at the multivariate results, we see something different. So these are odds ratios from logistic regressions that are predicting these outcomes. Do they not have insurance versus do they? Do they have delayed care? Do they have no usual place of care? And so we see here that children living in the new destinations are more likely to be uninsured, as well as to have no usual place of care than those in the established destination in this adjusted model. But these disparities are not just restricted to the new destinations. We also see that Fast-growing hubs, which are established destinations that have high growth, also are more likely to have delayed care and no usual place of care. And then that no usual place of care disparity is actually in minor destinations as well. So there's something going on with no usual place of care where all of the groups other than the established groups are more likely to not have a usual place of care than those in established destinations. This is from an interaction model where we interacted destinations with the racial, ethnic, and immigrant origin group. And I just want to point out here that we did find a significant interaction in predicting non-insurance or uninsurance for the Latino children of immigrants group. So as we see here, the Latino children of immigrants living in the new destinations, they are the most likely to not be insured of any group here. They have wide disparities with white and Black children within destination in not having any insurance. They also have a gap with their peers from the same background in established destinations in not having health insurance. And so we see that this sort of uninsurance disparity, both within and across destinations, is greatest for this Latino children of immigrants group. So in sum, we see disadvantages in new destinations in terms of uninsurance and no usual place of care, especially for these Latino children of immigrants. We also see disadvantages in other non-established, sort of stable, other than the stable established destinations. So delayed care was more likely in fast-growing hubs, no usual place of care more likely in non-established destinations. And these results for children are consistent with previous findings on disadvantages in health access and utilization among adults in new destinations. And so this is the last study that I'm going to show you. This is work in progress. So I'm looking at early childhood health across destinations because we know how important the early childhood period is for later life outcomes. And so this analysis is really, it's using the NHIS data, but I'm restricting the focus to children who are ages 0 to 5. So I'm using a very similar data set that I talked about in the last study, with the exception that I extended 2010 to 2018 for the sample of analysis. I'm using the same destinations typology, and again, the NCHS analyst is doing all the data setup for me with the restricted geocodes. I'll show you this disclaimer again and their ERB approval statement, just so you know that these views are my own. So I've got this sample of 0 to 5-year-olds. So the full sample, I have just over 21,000 children who are ages 0 to 5. And then for the subsample, for those measures that are only for the sampled child, I have around just under 10,000 children. And for the results I'm going to present here, it's a Latino only sample. So I'm just comparing Latino and Latina 0 to 5-year-olds to one another. And this is how they're distributed across destinations, with about a quarter of them living in these new destinations. I'm going to show you an array of outcomes that I measure. And I'm not going to go through the whole list, but you can see. So I look at health access and utilization. If the measure has a star, it means that it's available for the whole sample. If it doesn't have a star, it's only available for the subsample. So I look at all these health access and utilization measures. I look at a bunch of relevant health outcome measures. And I also look at these measures that are referred to as child strengths and difficulties. These are only available for 4 to 5-year-olds in the sample. These would be sort of things that we think about, like difficulty with emotions, not having good attention, or being worried. And sort of the kicker of this is that when I'm comparing the Latino children across destinations, just that group, I'm getting all null results. So I'm not finding significant differences across new and established destinations for pretty much every single measure in that list. There's a couple differences for health access and utilization. So there's actually an advantage for the children in the established destinations forever visiting the dentist. So that is slightly lower in the new destinations. but the children in the new destinations are more likely to have gotten their flu vaccine. I have a lot more that I want to do with these data. I want to look at Latino and peer differences in these outcomes, both within and across destinations. Also look at differences by parental nativity and national origin, and look at destination interactions with some health context variables. So this is very much work in progress. So to summarize the work on the child health outcomes, we find that in childhood health access and utilization disparities in new and other non-established destinations are pure, but in early childhood and within the Latino group, we're not finding very many differences in health and health relevant outcomes, and mixed results for preventative care, right? Where children in the established destinations are more likely to go to the dentist, but those in the new destinations are more likely to get a vaccine for flu. So my overarching findings are that new destinations have many positive aspects of their health context, but they lack some safety net health resources that immigrant groups or immigrant origin groups are likely to use the most. And I find mixed evidence across my studies of health utilization and access challenges for Latino children, with variation in the results according to child age, as well as heterogeneity by subgroup type and depending on who the reference group is that we're thinking about. And so I keep coming back to this question of whether destinations matter relative to other contextual factors. So for the work on FQHCs that I've been doing, it really looks like segregation is a much more important predictor of FQHC supply than our destinations themselves. Also, sort of the null results for the Latino early childhood health outcomes I'm getting, I'm just wondering, maybe it's not destinations that matter. Maybe it's some other aspect of community or of families that matter. And I also, with these results, think about, do we need to be thinking about an established destination advantage rather than a new destination disadvantage? So are there group-specific assets for health and well-being in established destinations? And how do these matter for health in these classic areas of settlement? And can or should these assets be replicated in new destinations? So I want to continue in my future work to keep characterizing the ecology of healthcare. I want to be able to link these health context patterns to health outcomes, sort of filling in the gaps in this framework here that I presented earlier in terms of mechanisms linking destinations to health and well-being. I want to look more at within group heterogeneity, in health contexts and health outcome patterns, thinking about destinations as an explanatory variable, a moderator, or neither. And then lastly, as we think about, again, new destinations not being new anymore, I think a really key question is, how are these communities changing and these resources within these communities changing, as well as the people themselves, who's coming, who's growing up in these areas, and the health patterns over time. So I think that sort of the next wave of research in this area really needs to think about change over time in destinations, in health contexts and outcomes. So I just want to acknowledge a bunch of people and say thank you for the support. These are my funders, and I am happy to take some questions.
Thanks, Liz. Okay, does anybody have any questions or comments for Liz? I don't see any in the chat. Okay, Emily, do you want to go ahead and just ask your question?
Yes, I'm always struggling to find the hand raise function.
Me too.
Hi, Liz, thanks so much. This was really interesting. We're chatting later today, so I will save some very specific stuff for the early childhood. But I had two questions. The first one is about how frequently the HPSA and medically underserved area status definitions change. So both in terms of like how often they're updated and how frequently counties are moving in and out of those definitions.
Yeah, so I don't know as much about how if they've changed the definitions over time. I do know, so I mean, this is like FQHCs specifically those are related to the MUA definitions. FQHCs are constantly shifting. So it's not quite an answer to your question, but I think that those are pretty stable over time, those criteria. But I do know like the FQHCs as a specific resource that is based on those criteria. They are being created. Some of them are closing. Some of them that are lookalike sites are turning into real sites. And so there's a lot of shifting in those centers, but I don't know that there's been so much of a shift. I also, actually, this is sort of a critique that I have of some of these criteria. So like if you look at the medical underserviced criteria, it's really based on like, do you have a lot of elderly people? Do you have a lot of children? Do you not have enough doctors? And are you like high in poverty? And I can actually maybe show you, let's see, I think I've got it right. Here's the IMU score. And so if you think about the places where Latinos live, for example, the infant mortality rate, that was the other one. So Latinos tend to be a very young population, right? So they're not going to have as many older people in their community, so they're not going to hit that criteria. Their infant mortality rates actually tend to be better than expected because of the sort of Hispanic paradox aspects. And then, like, as you can see in the new destinations, the poverty rates are actually lower than in the more established ones. So and there's no specific criteria in here for being like an immigrant origin population or members of a specific racial and ethnic group. So it is kind of interesting to think about like how these criteria might be missing some Latino communities. But I don't know, that's a good question. I don't know if this like scoring and these criteria have changed over time at all.
Yeah, that's really interesting. Thank you. And if you could go back to the slide where you had the map with the new and established destinations. Yeah, so one thing, so there's obviously like a lot of state level clustering in what's established and what's new. And so I'm curious if you've looked at, particularly for early childhood, it's like it's such a huge ball of wax, so I think this would operationally be very difficult to do. But have you thought about variation in both state level programs for early childhood health and then who qualifies for those services in what states by legal status?
Yeah, I think that's a really great point in trying to think about like these nested contexts, right? And thinking about in some of our other work, I think we just threw in state fixed effects to just like wash away any differences. I'm pretty sure the paper with Stephanie did that, where we just threw in state fixed effects and like that took care of state level differences. But I think, yeah, you have a really, really good point there. Yeah, and I think we did look at 287G specifically as a policy in the paper with Stephanie, and we didn't really find that it was an important predictor of health utilization among that group. And I think we interacted that with destinations and didn't find anything there either. But I think it speaks to the importance of sort of thinking about like both county level and state level sort of bundles of variables that are going together that could promote or inhibit this early childhood health access and health outcomes. So yeah, I think that's a really, really good point.
Yeah, and I think increasingly, or at least in the next few years, I wonder how much city-specific programs, just to complicate things further, if they're going to be city level programs that come on board more, or other programs through school districts, just to add some more complication.
Yeah, no, it's a really, really good point. And it's even hard, you know, we've thinking about sanctuary cities and how do you measure a sanctuary city and is that really protective? It's actually very difficult to measure a sanctuary city. The way a lot of people do it is just, you know, if the sheriff is not handing people over to ICE, they're not doing the detainers, but it's a lot more than that. I know one of my grad students who I work with right now, he was on a project when he was at UC Riverside doing an MPP where he had to call every single city in California that they thought had a sanctuary policy and just verify that they did. So it's a real data collection challenge, I think. But I actually am hoping with like Trump 2.0 that there's a lot of people who are data nerds like me who are interested in doing this kind of collection and catalog so that people can use these data for things like this. But I think that's a really important point. It's just a very big, like getting the policies themselves, I think is pretty straightforward, like at the state level, but when we start thinking more at the county or city level, it's a lot messier.
Great. Well, thank you. And we obviously support all of those data collection and dissemination efforts here.
Thank you.
Any other questions? Oh, Angu, did you want to go ahead and ask your question?
Thank you so much for this presentation. It's super interesting to me because I'm actually really interested in ethnic neighborhoods in MENA and South Asian communities. And I developed for my dissertation some sort of a typology, but not on old and new destinations. So I feel like that's pretty, like I've seen that in the literature on the Latino immigrant communities. I thought more of I thought more about like social and economic, how would I say this, level differences at the neighborhood level for those different communities and how they might be like have different like patterns, I guess. And one thing that emerged from that data was some differences in even like the countries of origin within that pan-ethnic communities. And I'm wondering if you noticed anything with your data and like the old versus new destinations, if they're kind of like certain like country of origin groups collected in certain type of groups or neighborhoods. And why not look at, your analysis by country of origin versus like the destination, like individual level differences versus like the destination level differences. And I asked that not necessarily to like challenge you, and it's more just because I get that question. So I'm like, how do you think about it?
Yeah, I mean, I don't take that as like I take that as a critique that can strengthen the work. So I appreciate it. So there's a couple of things. So I am like for the last set of results I presented, I am going to break those down by national origin. Again, when we think about these destination level differences, the group that has the most geographic heterogeneity is the Mexican origin population. Because the other groups, even though like Puerto Ricans, Cubans, they are, they don't live just in one place. They are dispersed. This sort of dispersion all across the country is really been driven by the Mexican origin population. And then, there are also some Central Americans as well. But it really is like more of a national origin story about Mexican migration and their descendants. I think you raise another really good point, which is like, what is the mix of people? So it's that idea of like, who was maybe there before, and then who was there now, and then how does that shape the utilization of resources? So you can think about a place like LA or even New York, where so LA is an established group, but they've got all these different national origin groups, right? The pan-ethnic Latino groups. You've also got New York, which was a newer Mexican destination, but it had these other Latino groups living there. So you can think about that and how that might shape sort of resources. You can also think about how that might also, if they were pre-existing resources, how people might see those resources as for someone else. So you could think about like in Kent County, if there weren't Latinos before, that there's these Latino, serving organizations, how the groups might think, oh, these are for us. Whereas in other places, when they had pre-established resources like Head Start or FQHCs, they might see those resources as being for other groups. So I think it's a really interesting point. I did also want to tell you that we are doing, for the FQHCs work, we are doing a neighborhood level analysis now, where we are looking at like diversity in the tract using the Teal index, thinking about like multi-group presence in the tract as well. So yeah, I think these are all really good points. And as a sort of like quantitative researcher, it's also, some of these questions are better answered qualitatively, I think, about like how does the ethnic mix in the neighborhood or the pan-ethnic composition shape people's likelihood to use these services or to engage in certain health behaviors. Thank you.
And thank you for that really thorough answer.
Any other questions? Everybody's being shy today, I think.
It's hard. Zoom is hard.
Okay, well, Rachel, how long do we usually wait? Because I know that you'll get lots of conversation with the folks who are going to stay after too. So.
Yeah, I know it's a little bit early, but I think that if they want, the trainees who want to stay on for the post-seminar training meeting can go ahead and stay on, and we might get a couple more that join in at 1. But I think anybody who wants to stay on can stay on, and everybody else, I hope everybody has a great day.
Great.
Thank
Thank
you.
you, everyone. Thanks, Liz, for coming. It was
Thank
super
you. Thanks for the
interesting.
nice introduction.
Yes, thanks.